So we will not be doing this every 2 weeks now. We'll be doing this every 4 weeks now because we have a whole bunch of other stuff we want to do. So, for example, we're going to have an introduction to neurofunctional integration going for 3 hours, which we're planning for the end of the year in English, so you guys can get more into the thing and maybe also use something or try out something in your practice. So, we have been talking about the nervous system, of course. We have been talking about the nervous system for the whole year now, and I'm talking about the nervous system since 18 years to my patients, to all the people I teach. Right now we're in Bad Kohlgrub. It's called a small town in the south of Germany. This is right near the mountains, and we're having a six-day seminar with the autonomic nervous system, or for the autonomic nervous system. Why 6 days? Because it's a lot of stuff we have to talk about. When we work with the nervous system, the autonomics might be the first priority we look at. Even if somebody is coming in with pain in his leg or joint or vestibular issues or whatever it is, the first thing we look at is what part of the nervous system is not working correctly and what part of the nervous system is not integrating correctly, and what's the cause of that problem. So we think in two categories. We think in the category of having a biochemical problem. That means maybe the brain or the nervous system is not getting enough fuel, glucose, oxygen, etc. So that's one part. The other part is more a mathematical part where maybe the nervous system is not calculating right. We say that's the electric part. So there's like a calculator, but a calculator, of course, needs some fuel to work, or a computer needs some electricity to work. So that's what we need the brain to have. So the way we look at this is that when somebody comes in, let's say a person comes in and he is suffering from knee pain or maybe leg pain or maybe muscle pain or something like that. We ask ourselves which part of the central nervous system is not working correctly or congruently or coherently with the leg or the knee or the muscle. So this is our first question. So that's what we use our testing for. Our testing is to determine what part of the central nervous system is not doing its job. So, of course, if you have a proprioceptive problem, for example, this could be the medulla oblongata, because all the proprioceptive, the big proprioceptive tracts go to the medulla oblongata. And, of course, you have the cerebellum, and, of course, you have some other brain structures, and, of course, you have the cortex. So if we determine, for example, that through our testing we think that the cortex for proprioception is not working as it should, we don't just start to try to work with that cortex by training it or by treating it or by stimulating it. First we go ahead and we ask ourselves 4 questions. So 4 questions we ask is, number 1, is there a problem with the cranium? Because if you have a problem with the brain, with the bony part of your head, this can affect your brain function. So why is that? Because the cranium, the bony part of the head, is innervated mostly by the trigeminal nerve. So the trigeminal nerve sitting also on the outside, but also on the inside, it's also sitting in the sutures. So the meninges are also innervated by the trigeminal nerve. So if you have some kind of problem with your trigeminal nerve, and that's what it is, it's not a problem with the bone, it's not a problem with the suture. If you look at it from a neurological perspective, it's a problem with innervation. So here you have a problem with innervation of your trigeminal nerve in a certain part of your skull. So since there's also one part of the trigeminal nerve going to the blood vessels, which are called the extrinsic blood vessels, mostly the extrinsic blood vessels are innervated by trigeminal nerve. They are responsible for blood supply to the outer parts of the brain. That's one part of it, but the bigger part of it, of course, is pressure regulation inside the cranium. That's very important because you have a bone which is very, it doesn't move a lot, okay? So that's what I want to say. So yes, one of the professors for osteopathy I worked with, he told me that they did a measurement, MRI measurement of the skull volume, and they did see skull volume changes in MRI. So yes, there is a fluctuation, a mechanical fluctuation of the skull. That's probably one part. But of course, the other part is that the skull is mainly a hard case in which the brain is embedded, and any kind of pressure fluctuation inside needs to be buffered. So the buffer system is the extrinsic system, the extrinsic vascular system, which is on top of the brain in the meninges, also going partly into the brain. And one of the main nerves innervating that system, besides other nerves, which I'm going to mention in a second, that's the trigeminal nerve. So the trigeminal nerve is innervating the extrinsic blood vessels of the brain. So now if you have a problem in the trigeminal nerve, maybe caused through a head trauma, you might get a problem with your vascular regulation, getting a problem or bringing a problem into the pressure regulation, also into the vascularization or the blood supply to brain areas. So that is a problem which has been identified even in minor head traumas, that you might get long-term blood flow restrictions or blood flow alterations after even minor head traumas. So that way, if we can access the trigeminal nerve in the cranium, we also get access to the vascular system inside the head. So not inside the brain, that's a different system, that's the intrinsic system, which has a different regulation, but that is one part of accessing that. So besides the trigeminal nerve innervating the blood vessels, of course there is also supply coming from the superior cervical ganglion, which is innervating the blood vessels, but also the glossopharyngeal nerves and also the facial nerve. Or parts of the facial nerve going to the autonomic ganglia inside the head, which then go to the blood vessels. So that part also we might consider, but right now we just want to look at trigeminal innervation of the skull leading to maybe changes in blood flow, which we cannot or have not yet proven to be correct, but we see changes in the function of the brain in terms of change in the function of the body. We see that, so we can assume that if we treat the trigeminal nerve of the cranium and then we see changes in body function, we might assume that it's a change in blood flow supply. So this is what we're doing, and I'm saying hello and I'm saying thank you for watching here. And of course we're recording this, and it's going to be posted on Instagram TV, so you can watch it anytime, go back and see what I said. And maybe watch some other stuff on our YouTube channel, because we have a whole bunch of stuff also in English. We have the whole seminar #1 available on YouTube to look at, also with the manual, to just study and see what we're doing with functional neurology here. So right now we have the case. So we have the skull and the innervation of the skull. The next thing we look at, we ask ourselves, is there a good blood supply to the head? So the blood vessels we need to look at are, of course, the vertebral artery, the carotid, and the internal and external carotid, and the carotid, the carotis communis, as I would pronounce it in German. So those are the main blood vessels we need to look at, because they are supplying the brain. And one, of course, is very important. The vertebral artery does not have such a strong motor innervation, because brain stem function is at a quite constant level, because it's supplying the body with a function like breathing and like heartbeat and all these things, or regulating heartbeat. So there's quite a constant blood flow going through the brain stem. But of course, if it's altered, it can be a problem. If you have a problem with your vertebral artery, yes, you have different problems like balance and maybe also like vision, because it goes all the way up to the occipital lobe. So, but one system that has a very strong motor innervation, which is the internal carotid, because the upper parts of the brain, they have a much stronger fluctuation of need for oxygen or need for glucose, so that has to be regulated a lot more. So if you have more regulation, you might also have more problems in your regulation. So what can cause that? Of course, also head trauma can cause blood flow regulation coming from the bottom of the skull, but also cervical trauma. So whiplash trauma, which is something I see very commonly. People coming in with a whiplash injury, maybe also even, I don't know, 5 years ago, 10 years ago, and they're suffering from some kind of pain in their body for a long time since that whiplash injury, and everybody's saying, well, we need to release your muscle and we need to release your dura so that works again. First thing I look at is what's the function of the blood vessel. So, of course, you can go right to the blood vessels and test them for their sensibility, how easily you can irritate a blood vessel, because you can palpate all the blood vessels at the base of the brain or in the neck. So you can do that. You can also do that indirectly, because sometimes people do not remember their whiplash, or they don't think it's important when you ask them, or they have really forgotten because it's been a long time ago, but they still say, well, since 10 years I have these pains in my back, going down my leg or whatever. And this could be a blood supply also of the periphery. This could be a nerve problem of the periphery, but it could also be a blood supply problem to that part of the brain which is responsible for the leg. So we need to look at, so when we test, we usually go to the periphery if people do not have a central symptom. So we go to the periphery and we start testing connections between the periphery and the central system. And then, of course, if we go to the central system, we ask ourselves, skull, I already said that, and then we ask ourselves next, what's the blood supply, or what's the correlation between that part of the head or that part of the skull and the blood supply to that part of the head. So that's what we test for. The next thing we test for is not the blood supply, but the outflow. So outflow in terms of lymphatics. Of course, when we do test the skull and we do test the sutures, there's lymphatics in the sutures, but this is like the lymphatic system in the cervical spine, the deep cervical lymph nodes, which are the first parts where the system is starting to pump away the lymphatics, the lymph fluid from the brain, from the head. And that is, of course, going down through the jugular foramen, where the vena jugularis is sitting, and there's the outflow also of the lymph tissue or the lymph vessels, and also you have an outflow of lymph vessels through the nasal part, lymph vessels in here going from the brain area into the nasal part, and then eventually ending up in the cervical and the cervical lymphatic tissue right here. So that's what we need to look at if that is working, because lymph vessels, if anybody told you that lymph vessels only work through muscle function, muscle tissue around them, or through breathing, which is causing like a dragging lymphatics into the thoracic region, well, that's completely wrong. I mean, it's not wrong, that's the way it's also working. But the main working of the lymphatic vessels is by contraction. So they have muscle tissue, they contract. And by contraction, they transport the fluid. And that contraction is controlled by sympathetic innervation. So in studies, you can see how that sympathetic innervation is blocked, and then the lymphatic vessel stops working, stops contracting. So they contract about every 10 seconds, something like that. That's like the basal rate. That can like go up tenfold if there's more need for lymphatic drainage. So yes, we have to look at lymphatic system in terms of innervation of lymphatic system, the innervation of the lymphatic vessels, the innervation of the lymphatic nodes for lymph transport. And we know, I'm not saying that we're treating that, but we know that lymphatics play a huge role in cleaning out the brain from all the stuff that's going on during the day, building up proteins and all that stuff. So then in the night, there's a whole bunch of fluid going through the brain, washing out all the debris that's there, and then bringing it away, transporting it away through the lymphatic system. So very important, enough sleep, very important, good lymphatic function, so the brain can keep up its good work if it's working well. Okay, so that's what we're looking at, and of course then we're looking at the activation systems, because the activation systems are the ones that are sitting inside the brain, and we call that the inside autonomic system of the brain, which is regulating mainly through neurotransmitters like serotonin, acetylcholine, and those things, regulating activation or the function of the brain, the activation level of the brain, but it's also causing a change in blood flow. So that, of course, makes a whole bunch of sense, because if you want to activate a brain region, you want it to work more, you also at the same time are going to need more oxygen and glucose for that to work. So you need a parallel activation of the neuron and a parallel activation of the blood vessels, because the neuron's going to need more oxygen and glucose. So makes a whole lot of sense. So that, of course, the way we look at that, we might talk about that in one of the next sessions. We have a special technique looking at that. What I want to show you now, and we have a few minutes, because I want to limit this to half an hour, so everybody's still interested after 20 minutes maybe. So we want to limit this to half an hour so we get some stuff done. We can talk about a few things here, and of course next time, and you can look at the old parts of NeuroThursday about all the things we're already doing in the periphery with the receptors and all that. So I have my dear friend here, Axel, who's also assisting my seminar, and we are gonna see if he has some sort of brain disorder. Yes. Yes, please. Okay. So we're going on number 2. So, yes. So, maybe he would come into my practice and tell me he hit his head, because like he plays ice hockey, so that might happen. You know, he gets a body check and he slams his head against the side of the playing field, so that might happen. It has happened a few times in the past, and that might happen again. So he might come in and say, well, I got hit pretty hard and I smashed my head, and we should look at his head to see what the autonomics in his head area are doing. So you can access that right away. And that's what we already did, because we already recorded a version in German, and we already looked at some function in his sutures. And we're going to try to find some more sutural problems, because he's playing ice hockey. Yes, that's very likely that we find something there, of course. So then that's more like the bony part, the skull, where we look at the trigeminal stuff. Then we might look at the blood vessels. Of course, we cannot access the blood vessels directly. Maybe through a stronger vibration is something we can use to access blood vessels or blood vessel function inside the skull. But first of all, we go through accessing blood vessels where we can access them here on the neck. So we can do that, and of course the lymphatic tissue is here, and the activation systems are of course inside the brain. So there's a different way of accessing those. So, but what we start with is the outside, and as I explained, outside correlates with inside. Maybe one story I can tell, there is, I don't know if it's already clinical application, but they have done studies activating the ophthalmic part of the trigeminal nerve on the outside with electricity. So they put some electrodes on here and they stimulate that, and then they see, because that part of the nerve has a counterpart inside the skull, that activates blood flow inside the brain. So this is connected. So the outside is connected to the inside. And as I said, here in the sutures, the nerve is not on the outside, but it's coming from the inside, so it has direct contact, you could say, to what's going on inside the head, the meninges, innervation of the meninges, and as I said, the innervations of the blood vessels. So one tool I use quite a lot when I work with the skull is a tuning fork, which has 128 hertz. I'm not saying this is the only frequency that will work. I'm just saying, or my experience is that this tuning fork works quite often when we check for mechanical irritability of the skull. 64 hertz might work, or even higher, 400 hertz might work, but I have the experience that this is working quite a lot. So I'm just saying hello, everybody watching. Okay, so here we are, and what I'm going to do is I'm going to test him like we always do sensory motor testing, muscle function. Some people right away say, and I mentioned this a lot, it's a kinesiologic test. I have no education in kinesiology. For me, this is just neurology. All neurologists are using muscle function for diagnosis. We're just using it in an indirect fashion, seeing if we can activate a part of the nervous system and see changes in sensory motor output. or motor output. Also sensory input could be modulated. So that works quite well. It's not the universal tool, but it works quite well. So what you can do is you can just kind of go ahead and just activate a part of the sutural system to see how it reacts to mechanical activation. So there's nothing going on here, so we can go along other parts of the sutures. Of course, we have to see, can just go down the coronal suture, see if anything is happening right there, and I can go out down the other part, and that way you can kind of search your way through that system to see if all the sutures are not reacting, not being irritated by mechanical stimulus. So let's go down, and I'm going to do it on this side first. Let's go down the squamous suture and just see if it gets irritated on that part. So there is a little irritation right there, and now you can just find it. So here I'm more near the sphenoid bone, so not much right there. I go further back. So those are areas that are quite exposed to being hit. Yeah, so whether you're wearing a helmet or you fall, or it doesn't have to be ice hockey, it can be anything else. You're just like leaning down and you're coming back up and somebody opened the drawer in your kitchen and you're like slamming your head. So that happens quite a lot in life. It doesn't take a lot. So it's not like you have to fall unconscious to have a head trauma. So sometimes it's just something where you say, oh, that kind of hurt. So you're rubbing your head for a while and then you're going back to business. But this can affect your ability to, or not your ability, the ability of the nervous system to function properly. So if we kind of go back here, and what I'm going to test is go more down here to the lower part of the lambdoid suture to see if he reacts there. No, that's pretty good. So it's more up here in this part of the sutural system. So there's an irritation right there. So what I'm going to do now, because that part is kind of near and I have to kind of wander around because I'm looking for something. So this part of the skull, if you look at this, this is where there could be some visual cortex issue going on. So this is the occipital lobe. We have visual system sitting right here. So this might affect the way the brain is processing visual information. So what I kind of like is to use like this, like an LED light, which is quite strong. So I kind of like to use this to get a strong visual impulse or strong visual stimulus. And since I want to stimulate this part of the brain right here to see if there's a reaction to light also, not only to mechanical stimulus, I would just use this, and I would, because to get it across to the left, I have to go to the right. Okay, so I would stimulate from right here, so I would have a stimulus on both eyes, stimulating the retinal part, which is right here, going back to the left side of the brain. So let's see if that's happening. It could be nothing is going on, but it could be that also would irritate him. Okay, so you just look straight, and all I'm going to do is I'm just going to flash the light like this a little bit. Okay. And that also irritates his nervous system. Okay, if I do this to the other side, okay, and I test him over here, so there's no reaction coming from that. But if I test him on this side, if I irritate him on this side with light, okay, so right now, and also he's feeling some irritation, so there might be also some like autonomic reaction going on there. So right now I don't know if the light stimulation to activate his visual system correlates with what's going on in his skull. But that's what I'm going to try to show you, is that if I treat the skull, if I integrate the skull, it's probably, I don't know yet, but it's probably going to take away his reaction to light. Okay, so that's a dysfunctional reaction. That's not a normal reaction right there. So we're going back to the tuning fork, and we're going to use this to go to his squamous, or the back part of the squamous suture right here. So going towards the occipital lobe, of course I'm not I don't think I'm vibrating the occipital lobe. I'm vibrating his skull. So his skull is vibrating, but probably not his occipital lobe. Okay? So what we need now is we need to find something that will take away that irritation. So we need to activate a part of the brain that will take away that irritation. So the first thing we do, because the meningeal parts of the trigeminal innervation, they go to the spinal nucleus, so the nucleus spinalis. So that's partly in part of it is in the medulla, part of it could also be lower. So activating something that goes towards the medulla is always an option when working with something like the sutures or the skull. So yes, that works. So that works quite a lot working with the head, because like I said, all the internal, also the sensory vascular innervation is said to go to the spinal part of the trigeminal nuclei. So that way we can flip the switch, and the head is saying, well, if you kind of activate my medulla going through here, glossopharyngeal nerve, hypoglossal nerve, whatever we have here, that works quite well. I can also switch to something else, activating the medulla oblongata by something else, like maybe he can activate his tongue. So he's going around with a tongue in his mouth. That's hypoglossal nerve, but also, of course, trigeminal nerve. The oral cavity is also something that is represented more in the spinal part of the trigeminal nuclei. So he can move his tongue around, activating, that's a motor activation, but also sensory activation. Then I'm going to activate his suture here again, and I'm going to see if that takes away the irritation, and it does. Okay, so now I'm switching from a contact point, and we have a fly going around here all evening. We're switching from a contact point to a functional activation, and that we can use for integration. So integration, like always, is activating parts of the skull. We don't know why that works, but it works quite well. So he can go around the mouth with his tongue, and I'm just going to turn him a little bit, and I can go over his suture with the tuning fork, and what I will also do is activate the parietal part of his skull. We use that parietal activation for all parts of the body, not just for the head. Okay, so we do that a couple of times, and that will integrate parts of his brain that are involved in sensory regulation, or maybe also motor regulation. So this is integration. Yeah. So now we test again. So we go back to that part of the skull, and we test this part of the skull, and then we test, and here he is not irritated anymore. So he's got no sensory motor output change by me putting a vibrational sensation on the skull. Now, of course, we want to know what about the visual stimulus, okay? So here he was, left side occipital cortex, yeah? So we're going to activate that again by flicking a light, and then we're going to see how he reacts, and he does not react to that. And he might also feel, and that's what I'm going to ask him in a second, he might also feel that if I flash the light now, it's probably not as irritating as before when I was flashing the light, because his brain is now processing that information a lot better. Okay? So, did that feel different when I flashed the light? Yes?
Yes.
Yes. Okay. So that's normal. Yeah, so that's what it is. First, when I flashed the light, he was kind of feeling irritated, and now it just doesn't make any difference because his brain is now processing the information properly, but the cause was probably not a visual problem, maybe caused by a flashing light or something where his visual cortex is going nuts. It was probably caused by a head trauma, which is a lot more frequent. We hit our heads a lot during our life, and I think we misjudged what it can do to our brain function. We think, well, this was not a strong hit in the head. Well, maybe not that one time, but maybe when the second time, the third time, the fourth time we hit our head somewhere on the post, on the door post or whatever, where we hit our heads, that might then cause the brain to say, well, I'm not really able to process information in that part of the brain anymore because I have an irritation in my skull, which is causing an irritation, which is basically not an irritation in the skull. It's an irritation in the trigeminal nerve, and the trigeminal nerve is also sitting on the inside. It's also sitting in the vascular system, and maybe that is causing the system to not work as good or getting irritated quite easily. So, this is how we fix stuff, And yes, perfect timing. I said I want to do this for half an hour on this. We have a perfect timing here. So this was the central autonomic nervous system. So we recorded this. It's on Instagram TV. It's going to be available on YouTube in maybe 2 weeks or so you can watch that again. And we're saying thank you, and I'm going to see if anybody wants to chat with us on Zoom right now. I'm saying thank you for watching and saying thank you, bye-bye on Instagram, and see you in 4 weeks maybe. Thanks.